Yes, sir. Online करना पड़ेगा.
Yeah, doctor, you can start.
Yes, sir. Side से ही.
Good afternoon,
Uh,
everybody. Welcome to this webinar on Carbetocin in action from Heathrow. Heathrow Healthcare has 25 years of excellence with 36 state-of-art manufacturing facility. We have 300 plus products in our portfolio and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. We have Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customer across India, wide product range encompassing multiple specialties, pioneering in quality and innovation, and we have a distinction of bringing 4 biosimilar products to market within 5 years of usage. Today's webinar, Carbetocin in Action. Carbetocin, we all know, is used for prevention of PPH, prophylaxis of PPH. And although there are many papers on PPH and its dangers and prophylaxis of PPH and carbetocin in PPH, we always like to have our own doctor's experience of use of carbetocin in PPH. For which today we have got Dr. Swati Jain with us. Welcome, madam. Welcome, Dr. Swati Jain.
thank you.
Dr. Swati Jain is MBBS MD from GMC Patiala. Madam has worked in MAMC Agroha, AMISR Batinda, and Madam is a member of Foxy IMS. Welcome, Dr. Swati Jain, and over to you.
Thanks so much. Currently, I'm working at my private hospital at Tohana, district Fatehabad. And at the same time, I'm working part-time at a charitable hospital also. So we have good input of patients here. So today we will be discussing about the drug we all are aware of, Carbetocin, which has been in the market for the last, I think, 1-2 years. And it is mainly used for the prevention of PPH, postpartum hemorrhage, which is we all gynecs call it the nightmare of a gynec. So Carbetocin is first let me give you a brief view about PPH. PPH is when there is loss of at least 500 milliliter of blood following a vaginal delivery and around 1 liter of blood following a C-section. It is a very common incidence, and even in women who are not at risk, PPH can occur at any stage. It is a leading cause of maternal mortality in low socioeconomic countries, and it is one of the major causes of nearly 1/4 of all the maternal deaths all over the world. Let's take a brief review of PPH, the statistics. Maternal mortality, it accounts for around 35% of all the maternal deaths all over the world. MMR in our country is very high. In India itself is very high. In developing countries, it's around 240 per 1 lakh live births compared to 16 in developed countries. And around 14 million women on a global level suffer from PPH. Its incidence is around 2 to 4% after vaginal births and around 6% after cesarean births. In India, as I have already told you, its incidence is quite high. 38% of the maternal deaths are due to PPH, which is very, very high. 25.7% of global deaths take place in India, contributing to around 2/3. So India has an unexpectedly high maternal death rate of 540 per 1 lakh live births. The major factors which contribute to PPH, the four main reasons, the etiology behind it is firstly atonic uterus, which is the most common reason which occurs. And this is basically the loss of uterine tone, which leads to the inability of the uterus to contract, and that leads to continuous bleeding per vagina. Then there can be coagulopathies also, some clotting disorders in some patients. Well, these can be genetic reasons, and they can be trauma, the tears, vaginal tears, injury to the birth canal, any rupture of the uterus, or any kind of lacerations or any inversion. And there can be retention of the placenta, any clots, some abnormalities in the placenta which were not diagnosed. So any clots and retained products can also contribute to postpartum hemorrhage. The clinical findings. So, when you view a patient, when you suspect the patient might be having PPH, what will you observe? The abdomen. The patient will have a tense, tender abdomen. There will be fall in blood pressure. The girth of the abdomen will definitely increase because the uterine cavity will be filled with blood clots. So obviously the uterus size will increase. There will be uterus tone will be gone, so it will be lax and flaccid and boggy uterus. So loss of uterine contractility will be there, and obviously fall of blood pressure can lead to maternal tachycardia. The pulse rate will be high and there will be visible vaginal bleeding. So clinically, we can grade PPH into according to the degree of shock. They can be compensatory phase, then there can be mild, moderate, or severe shock. The blood loss in case of compensatory PPH is around up to 1 liter. So that will be around 10 to 15% of the blood volume. The blood pressure change will be minimal or nil, almost nil, and the patient will only have slight tachycardia, some palpitations, and dizziness. In case of mild shock, the blood loss will be around 1 to 1.5 liters, that is around 15 to 25% of the blood volume. There will be slight change in blood pressure, there will be hypotension. The systolic diastolic blood pressure may vary from around 10 to 20 millimeter of mercury, and patient will complain of weakness, there will be sweating, and tachycardia will of course be there. In moderate blood loss, when the blood is lost from 1.5 to 2 liter, around 25 to 30% of the blood circulatory volume, there will be marked blood pressure fall. Systolic falls to around 70 to 80 millimeter of mercury. The patient will be restless, will you can see that the patient is very pale and the urine output will decrease. And in case of severe shock when the blood volume is 2 liter to 3 liter loss of blood volume, around 45% of the blood has patient has lost, and BP will fall and the patient will almost collapse, ask for air hunger, there will be loss and urea also, that is renal decompensation will be there. Mm, then how will you evaluate a patient of PPH? First of all, you visibly, obviously, you can see that the patient is decompensated. There will be tachycardia, there will be hypotension, and there will be vital assess. We can assess the vital signs and visibly how much blood loss is there, and we can and see for the entire genital tract whether there are any tears or lacerations, if there is any hematoma, do you see if any there are any signs of uterine rupture, or you can see for manual examination if there are any retained products of placental tissue or any bits are present in the uterine cavity. You can also check with an ultrasound if you have it available to see if the uterus is lax or not contracted, and you can check for inversion also. And for laboratory tests, you can go for a CBC, complete blood count, and check for hematocrit and platelet levels, and coagulation profile. You can also get it done. How do you approach a patient with PPH? First of all, major reason is we all know it is the poor uterine tone. So first of all, you will palpate the abdomen of the patient. Agar if the uterus feels relaxed, it is boggy, it is soft. So uterus, the fundus of the uterus will be way well above the umbilicus, considering that it is full of clots, blood and clots. So of course, the height of the uterine fundus will be very high. You can go for a CBC, complete profile, coagulation profile, to see for if there are any coagulation disorders in the patient. Urea creat, you can get it done for the renal functional tests, and ultrasound you can get it done to exclude any rupture or any intraperitoneal signs of bleeding. And the patient, if the patient is not responding to even fluids and even blood you are giving and the patient is not improving, and the management includes the uterotonic agents, we can give that, like oxytocins, prostaglandins, and ergot alkaloids, methyl ergometrin and all. And you can prevent it with uterine balloon tamponade also, it can also help in management. And if there are any tears or trauma, you can see that clinically. The bleeding from the trauma site will be visible. You can see that if there is any extension of the uterine angles, like in cesarean section, there will be bleeding. And if there is any signs of rupture, and during C-section, there might be tears might be there. And extragenital causes can also be there, like liver rupture can be there, or subcapsular liver rupture, or rupture of the ovaries or splenic vessels. The investigations we can do is we can inspect during cesarean. Obviously, we have already patient is open in front of us, so you can see by exteriorizing the uterus if there are any tears, and ultrasound can of course help in case of uterine rupture. And like you are trying for a VBAC, and you cannot see clinically from the external side, so you can with an ultrasound you can see if there are any internal ruptures. There will be fluid in the abdominal cavity, and the scar site you can see the fluid coming out, and hemoperitoneum. And management, of course, genital tears you can always stitch them, and they can be arterial embolization you can do in case there is any broad ligament or supralevator hematomas which may need detailed examination. Retained placental tissue can be can be bits of placenta, sometimes membranes can be there in the uterus, in the cavity. You can examine bimanually, and you will feel the placental tissue with your examination. And sometimes the patient may also need to get examined under anesthesia also if you want to check the cavity in detail. And management you can do manually, remove the placenta. Sometimes you have to remove it with your hand manually, and that will be done under regional or general anesthesia. And coagulopathies can be, they can be continuous bleeding. Patient with no history, they have continuous bleeding, uterus is well retracted, contracted, there is no tears, but still patient is bleeding, so we suspect that there might be some blood circulation disorders in this patient, which are generally genetic. And for that we have to get the investigations done, the CBC, the coagulation profile, the PTINR of the patient, BTCT, all these tests. So therefore all these tests should be done well in advance. And urea creat we can get them done. And its management is basically you have to remove, you have to replace with blood and coagulation products. You can give coagulation factors, platelets, according to the uh, according to what are the findings. And surgical treatment is done in cases of trauma and in cases of hemorrhagic atonic uterus, or which is not responsive to medical management. Rationale for the development of carbetocin, which in new heat stable formulation. Now carbetocin, the benefit of carbetocin over oxytocin is basically it does not need refrigeration. It is available at room temperature. It is available at room temperature. It is a stable formulation, and it is available in a convenient vial form. So with Sinto and other ergometric alkaloids, they need to be stored in a refrigerator to avoid any degradation. Uh, a heat stable formulation of Sinto is currently not available in the market. The previous formulation of carbetocin that was available, that had to be stored between 2 to 8 degrees centigrade. Resource poor countries do not always have a cold chain transportation and storage capabilities. So now which the new formulation that is room temperature stable is, its benefits are it has a higher shelf life, increased shelf life of around 24 months at 30 degrees, and with 75% humidity. It avoids need for cold chain storage and any extra logistics, and it is provided in a vial form. So when do we need the uterotonic agents? Well, uterotonic agents mostly are needed in almost all cases of deliveries. When do we administer? We can provide it at the time of the crowning of the baby, head of the baby, at the delivery of the anterior shoulder, end of the second stage of the labor, and following the delivery of the placenta, sometimes when we suspect there is excessive bleeding. And prophylactic use can be done if you want to prevent PPH, and in the active management of the third stage of labor. Therapeutic use, obviously if there is PPH, so we have to manage it with uterotonic agents. The agents that are available in the market are oxytocin, carbetocin, ergometrin. Symptometrin is a combination of oxytocin plus ergometrin, and then prostaglandins, misoprostol, and carboprost. Carbetocin is a next generation drug for PPH management. Carbetocin, it was created by making some structural modifications in the oxytocin structure itself, which has led to increased half-life of the product, and it has reduced the enzymatic degradation. So the benefit of carbetocin over oxytocin is it has a higher half-life, so it can provide benefit for a longer time. It is a synthetic drug. It has a longer acting analog of oxytocin. Therapeutic indications are in use of PPH, especially which occurs in cases of uterus atony. And one vial, it is available in a vial form which contains 100 microgram of carbetocin in a 1 milliliter solution for injection. Clinical evidences. There was a trial which was conducted by WHO for carbetocin. It is named as Champion trial. That is study design was basically, it was a double-blind randomized study. Objective was to compare the effectiveness and safety of heat-stable carbetocin to oxytocin in prevention of PPH after vaginal birth. There were around 30,000 women were enrolled from over 10 countries, including India. As I have already told you, the trial was conducted by WHO, Department of Reproductive Health and Research. The primary outcome that was seen was the proportion of women with blood loss of at least 500 milliliter of the use of additional uterotonic agents, the proportion of women with blood loss of at least 1000 ml. So what was observed that the efficacy of carbetocin was almost similar to oxytocin. The parameters which we were observed was blood loss of more than 500 milliliter or the use of additional uterotonic. The efficacy of carbetocin was, as you can see, comparable to oxygen, around 14.5% both. And blood loss of more than 1 liter, and the efficacy of both around same, 1.5 and 1.45. And any adverse effects, the safety profile is almost comparable to oxytocin. So the frequency of blood loss of at least 500 milliliter or the use of additional uterotonic agents with carbetocin was proven to be non-inferior versus oxytocin. The use of additional uterotonic agents, interventions to stop bleeding, and adverse effects did not differ significantly between the two groups. So it was non-inferior to oxytocin for the prevention of blood loss or the use of additional uterotonic agents. The Cochrane review suggests that carbetocin, according to 11 studies conducted involving around 2,600 women, the Cochrane review concluded that for women who undergo a cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal deliveries and is associated with significantly fewer adverse effects. So guidelines, as we can see here in the graph, that almost all the societies all across the world, be it WHO, be it SOGC Canada, be it New Zealand Gynae Society, FIGO, and German Australian Society and FCOG France, they all have included carbetocin in their PPH prophylaxis. All our latest guidelines after these are 2015, 2017, be it, and they all consider carbetocin to be a good uterotonic agent, and it can prevent PPH to a greater extent. And the dosage, as they all have mentioned, it is around 100 microgram IV bolus. You can give it over a 1 minute IV, and its results are comparable to oxytocin. I have had experience with the carbetocin. I can share with you a few cases which I have had in the past few months. First of all, there was a fourth gravida female. She was already had 3 live births, 3 vaginal deliveries, and she was severely anemic, had a hemoglobin of 6.57 something, and we were suspecting that there might be bleeding per vagina because of considering she's grand multipara and plus also the she was anemic. So after delivery she had slightly more bleeding, so I gave a shot of carbetocin, and the uterus wall was well retracted, and patient was managed very well, and all blood pressure, pulse rate, everything was within limits, everything was normal, and we were able to manage that patient well, all thanks to carbetocin. There was another case of a twin pregnancy. She was term pregnancy, previous C-section. During cesarean, the bleeding was normal, but after 2-3 hours, we thought that there were 2-3 pads. She already were already changed of the patient, so I thought of giving carbetocin to the patient to be on the safer side, and the bleeding declined markedly in that patient, and uterine contractility was very good, and even that patient was managed very well with carbetocin. And there was another patient. She was a previous C-section. She was placenta previa, and during cesarean there was oozing from all the from the placental bed. After removing the placenta, it was adherent at places. So I gave a shot of carbetocin in during stitching only, and there was no excess case problem of excessive bleeding after delivery. The condition of the patient remained stable, and the patient had an uneventful post-operative period.
Thank you so much, madam. It was nice hearing your cases, especially patients with anemia, where we expect. And
Yes.
immediately after carbetocin, the uterus contracted and we did not have. Since how long, madam, you have been using carbetocin?
I have been using it for the last 6 to 8 months, I think,
Okay.
because it has become particularly like in areas like I'm working in Tohana. It is not a obviously 2 tier, 3 tier. So we come to know about these drugs a little bit
Understood.
late,
Later.
after 3-4 months when in Delhi, Gurgaon, you people start using it, and then we start
Correct,
using them
correct,
after 3-4 months
correct.
later. But it has very good results.
And you use
And
generally use intramuscular or intravenous?
I give IV
I
mostly and
yeah,
over 1 minute.
for
Most of
1 minute.
the patients,
Correct,
IV
correct,
over
correct,
1 minute.
correct. And which patient profile, although you said that uterus atony is one of the common causes, where doctors can anticipate a PPH, although PPH you can
Yes.
anticipate in any patient, but then there'll be
Yes,
some patients
PPH
who's
can occur in any
yeah,
patient.
yeah,
I
correct, correct, correct,
agree.
correct.
You cannot anticipate, but when there are some case scenarios like patient is having low hemoglobin, like this one, the case I had,
Yeah,
less than 7 gram, you always suspect that uterus might lose its tone or there might be bleeding because clotting is
correct,
somehow
correct,
deranged. And also in cases like fifth gravida, fourth
correct,
gravida, in
correct,
these
correct.
ladies also
You,
atonicity is very common. Then this there can be twins and triplets when there are
yes, yes.
multiple gestation pregnancy, high amount of liquor, polyhydramnios. In such
Diabetes
kind of
also.
patients, you can suspect. And like in previous cases, the when the sinuses get opened up, so the patient may have a little bit of
More bleeding.
increased bleeding. Yes.
Correct.
So in such cases, you can always suspect that
Yeah.
you may have to keep these drugs ready. And in countries like India, anemia will always remain the
Yes,
major
yes.
factor.
And little loss of blood can change the hemodynamic parameters immediately.
Parameters
Yes.
significantly.
Yeah,
Like
yeah,
they are
yeah. Correct.
already compromised.
Compensated.
They
Yes,
have
correct,
a
correct,
they do not go for blood transfusions.
correct,
There are
correct, correct.
myths considered that you do not get blood transfused in pregnancy and all.
Yeah,
It
yeah,
will
yeah.
lead to labor. So sometimes they think we have had previous deliveries with 5 grams, 6 grams, so I will get it all done also. Nothing will happen to me. And then there can be economic reasons also.
Yeah, 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 correct, correct, correct.
Low socioeconomic ladies, they keep giving births to 3, 4, 5 children.
Correct.
And for such cases, PPH is very common in this kind of ladies.
When would you actually prefer carbetocin or oxytocin for prevention of PPH?
It's not like I prefer, it's not costly also. We cannot say that it is costly. But in certain like these high risk cases, I
Yeah,
always keep carbetocin ready. Oxytocin, obviously, you cannot give carbetocin for induction of labor.
oh, yeah.
So oxytocin we already have. So and mostly we have been using it since long. So it is out of habit that we are using oxytocin.
It's our
But I
textbook
think
brand.
in the next year or two we will start switching to
Switching.
carbetocin only. And
One of the
in
major advantages you'll agree with me is that you don't require a cold chain, which is very important in our
Yes,
country.
you don't require a cold chain, you don't need multiple dosages,
Correct,
and
correct, correct,
it's
correct.
longer acting. And
Especially in the
side
period.
effects, yes, hypovolemia and all with the oxytocin you have to look for, because it has a
ADH effect, yes,
anti-diuretic
ADH.
effect also. So we have to look for that also.
Correct.
So I think in next few years, carbetocin is going to take
Completely
over
replace.
oxytocin. Yes, definitely, definitely.
Can we use carbet? Your experience, madam, have you used carbetocin? Have you
Personally, I haven't used it as of yet, but I think in future, if I have had some such kind of scenario, I might use it because
correct.
it gives good contraction to the uterus, give and sustained contractility for
Especially in
around
the upper segment, yes.
6 to 10 minutes, and so I think it will be helpful in future if I may need. But as of now, I have not used it yet because
I mean, it's
I
a,
haven't
yes.
had such case as of yet.
And in case of RH negative mothers,
Yes, I don't think there's any contraindication. For carbetocin, I think contraindications are only in eclampsia,
yeah.
in epilepsy, and
RH, RH
heart
negative
condition.
mothers, yes.
Yes,
Even little bleeding can cause havoc.
yes,
Yes, yes,
in
yes.
those cases, and when you don't want extracellular blood volume to volume to increase suddenly, in such cases you should avoid carbetocin.
Correct.
Otherwise, all
You
other
can.
rest of the cases it can be used, I think.
Can a doctor use carbetocin? This will be very common in our country for prevention of PPH if oxytocin is used for labor induction or
Yes,
augmentation.
yes,
Yes,
we are using.
exactly.
It cannot be used for induction.
Yeah,
See,
of course.
carbetocin is not a drug for induction
Or even
because it
augmentation,
gives
yes.
very sustained and strong contractility to the
Correct,
uterus.
correct,
So
correct.
it can lead to uterine rupture if you use
Absolutely.
it for induction. This
Induction.
should be kept in mind. But yes, for prevention of PPH, definitely,
You can do.
carbetocin has an upper hand because when you suspect that there will be bleeding, then definitely go for it. And both drugs obviously can be used. Oxytocin for induction of labor is used in almost 80 to 90%
Every,
cases
yeah,
these
yeah,
days. Naturally, patients they do not deliver for 2 days.
yeah.
Every
Correct,
place you have to go for induction with oxytocin only,
correct.
and you augment with the oxytocin. And carbetocin is given after delivery in all the cases, I
Yes,
think.
yes. Oxytocin is something which we have read in our textbooks over a period of years, which will
Yes,
always stay.
oxytocin,
Yes,
oxytocin is a good drug. It is a
yes,
wonder
yes.
drug, and it has its own uses. It can
Correct,
never be
correct, correct.
replaced. But
No,
yes,
no, no, but
in
yes,
cases of postpartum
there will be
management, I think
alternatives.
carbetocin will take over
Good,
in the next
good,
few
good.
years.
You have been preferring IV over IM all the time. Any place for
IV
IM you
route,
have been?
yes, वैसे तो I think both the routes, IM route when you want longer action, longer duration of
Correct,
action.
correct.
Uh,
May,
I think IV route it starts to work in within 1-2 minutes. IM route will take 3-4 minutes. And with IV, when you want quick action, then go for IV route. If you
correct.
want longer action, sustained action, then go for IM route. When I want that, in cases of multigravida, I want that there should be a sustained contractility of the uterus because the uterus keep losing tone after few hours, because the muscle tissue is compromised because of multiple
Hmm,
deliveries. So
hmm.
in those cases, I would prefer IM when I want prolonged.
Longer duration.
Yes, and when I suspect that it is bleeding, patient is having bleeding, and I am in panic, so I will go IV, go for IV when
Correct.
I want within 1 minute, the action within 1 minute.
If patient is not responding adequately with carbetocin, which could happen in any patient, what additional uterotonics that can be used?
Well, to be frank, I have, as of yet, I have not needed any other drug
Thank
after
God.
using
Thank God.
carbetocin.
Yes.
My results have been, I have got good results, touch wood, with
Yes.
carbetocin, in whichsoever cases I have given it. But yes, if there is no control, then we can go for other
Any of
gut
those.
alkaloids. We can give methargin, we can give carboprost, we can give these drugs as well if the patient is not
Doesn't respond.
yes, not responding to carbetocin.
I mean, we will use everything possible in such patients because you have to save the life finally.
Yes, yes.
Yes, correct.
You have to go for
Exactly.
whatsoever comes into your hand.
Available. Correct.
You
Correct.
can use uterine packing. You have to just prevent blood loss. You can do anything. PPH we all study.
Yes. Yes.
Management of
Yes.
PPH. Nowadays, the uterine embolization is
Yeah.
done
Yeah.
in
Yeah.
good
Yeah.
centers. Then even hysterectomy is to be done in time. If there is excessive blood loss, more than 2.5 liter, patient goes in irreversible shock. You cannot save the patient. So if needed, you can go for hysterectomy also when all other measures, medical measures are not
Correct.
helping you out. So you have to decide quickly.
My seniors were telling me while you manage PPH medically, ask someone to keep the theater ready because something
Yes,
happens.
always,
Yes.
always.
Correct. Correct.
PPH is this is why it's called a nightmare,
Correct.
because when it happens,
You
you
don't
know,
know
being
how.
a human being, you always go into panic mode. Everybody can.
Absolute.
And
Um,
patients nowadays, with the reporting and media, they have
Are
become
Baba.
anti-doctors. So
Yeah.
you have to be careful with every case, and they will always take 1 minute to blame the patient,
Yes.
not
Yes.
the
Yes.
patients, but the
Relatives,
public,
people
public.
surrounding. Yes. Yes. Yes.
The people from their village,
Correct.
they will
Correct.
start
Correct.
saying कि डॉक्टर ने कुछ किया होगा,
Yeah. हाँ, बराबर.
तो ऐसे कैसे हो गया, बिल्कुल भली चंगी तो थी, because they think for
They
PPH
don't
to occur
realize.
there
Yes.
must
Yes.
be
Yes.
some
Correct.
symptom. With this is what they need to know, that PPH can occur in any woman at any point of time,
Anytime. Yes.
and we need to take precautions before every delivery, considering that
Absolutely correct.
every patient is
Has a
prone, and
potential.
every
Yes.
patient we have to take the same measures.
Correct.
So बस
P-
वही है कि
PPH is
keep
best to
your
be yeah, PPH is best to be
PPH kit
discussed.
always ready, always
And,
ready with you.
and this condition is best to be discussed, best to be read, but never to be seen.
Best to be prepared, and keep your fingers crossed and have
Yes,
faith.
yes, yes, correct.
Yes.
What are the, you have actually told them, said this, carbetocin
Yes,
advantage over
advantage is
oxytocin.
yes, because it has a longer half-life, multiple dosages are avoided. Then side effects like carboprost, misoprost, they cannot be used in hypertensive patients. They can lead to high blood pressure. They can lead to nausea, vomiting, headache is very common with carboprost patients. They suddenly start having they can be cardiac arrhythmias. You
Correct,
cannot
correct.
give to cardiac patients.
Hmm.
And ergot alkaloids, they can have a anaphylactic reaction also
Oh,
sometimes, because patient
and,
can be allergic to them also,
and blood pressure
and
can shoot up.
blood pressure can shoot up. And with carbetocin, you have to be careful if you
Yeah,
have a patient of eclampsia, but
correct, correct.
otherwise, always heart condition, renal conditions, you can always compare benefits over risk over benefit ratio is there. And mainly to only it's quick action and
Yes,
longer duration of action, and heat stable. That is
yeah,
the
correct.
main advantage it has over other drugs.
Should carbetocin be kept? I mean, these days are gone where it can be kept as a reserve. Maybe it is the first line. There's no point in keeping
Um,
it as a reserve.
yes,
It's such
it
a
can be used as a first line drug. I think
yeah,
in
exactly.
future, as I have told you,
Mhm.
it might be we can start using it as a first line drug,
Mhm.
because
The,
till
con-
now
the
we haven't
condition is such
found.
that patient can die. I mean, the condition is very dangerous. So better use it as a
Yes,
first line.
yes, yes,
Yes, rather
yes.
than.
So it should be kept in the your PPH
Yeah.
equipment only. It should be one vial should always be kept ready. So it is a first line drug, I would say, not a reserve drug.
No, no.
Yes.
How would you compare adverse effect profile? I mean, you have already said this. ADH, especially ADH related adverse effect. Are
Yes,
they very
ADH
common, madam?
related.
Are they very common ADH related adverse effect with oxytocin?
Oh, no. Actually, we do not give excess of Cinto. It
Okay.
happens when you give 20 units, 30 units,
Okay.
40
Okay.
units. So if you give it in moderate amount and monitor the output of the patient, so I don't think these kind of conditions. Then of course you have to be vigilant with every drug you administer.
Yeah. That
You
is
have to be
correct.
vigilant with
That
the
is correct.
output, with the blood pressure, with the pulse.
That's
These
really
things
correct.
need to be taken into account in all the cases. So you can always bypass these effects if you are vigilant after delivery, and be cautious not to excessively use. People start giving Sinto 5 यूनिट और ऐड कर दो, इसको कॉन्ट्रैक्ट नहीं हो रहा है 5 यूनिट और ऐड कर दो 5 यूनिट, वो तो that these conditions can lead to, you know, in a
Yes,
panic
yes.
mode. To
Yeah,
do everything, you just put in everything. So
correct.
I have seen
Yeah, the condition.
40 units of Sinto people they use. So in such cases, then there might be symptoms of
Awesome.
ADH or all that.
And finally, your one-line message to the audience about carbetocin.
One line message that Carbetocin is a wonder drug. I have had a good experience with Carbetocin, and I suggest and I would say that every gynec should have at least one vial of Carbetocin always available in your PPH kit, because at times it can save lives. Carbetocin can help you save lives.
Madam, thank you very much. It was nice hearing your insights on carbetocin and PPH. It was
Haan ji,
lovely,
thank you.
especially place of carbetocin. And this practical experience of doctors are more important than theoretical, reading theoretical.
Yes,
अपना
yes.
country की बात
Agree.
अलग ही होती है, because every country's this thing is different. And coming
Yes,
from
yes.
different places of country, that's certainly good. Thank you very
Yes,
much for
agree.
taking time. Thanks
Thank
all
you
the
so much
doctors who took
for having
time.
me on board.
Yes.
Yes, thank you
Thanks
so much.
all the doctors who took time and attended this. Thank you marketing team for conceptualizing, field people for coordinating, and thank you IT team for your support. Thanks, madam. Once again, I wish you a very pleasant afternoon. Thank you.
So much. Thank you.
You can log out. Huh?
Okay, thank you so much.
Ravali, you can log out.
Yeah, thank you, sir.